Hello again, welcome. It is very late, that's why I'll try to keep my presentation short and brief. Today, I'll be talking about autism spectrum disorder in adolescents and the characteristics and behavioral problems of these adolescents. Autism spectrum disorder is a heterogeneous neurodevelopmental disorder. We know its definition. In my presentation, I will elaborate on three areas: social communication, reciprocal social interaction, two patterns of restricted, repetitive behavior. These three components are very pivotal for us. Adolescence is a period in which there are significant physical, cognitive, emotional, behavioral, and social changes for autistic individuals. The maturity of adolescence and the difficulty of new developmental tasks arise, such as formation of high-quality friendships, acquiring an autonomy from parents, forming romantic and sexual relationships. These are among the most important components of adolescence, puberty. Adolescence is a period during which we see the emergence of many social, emotional problems, including depression, anxiety disorder, a broad range of domains of problem behaviors that include risk-taking, alcohol and substance use, aggression and violence. ASD adolescents share the same risks and may face additional vulnerabilities during this developmental age. Adolescents and ASD. Actually, when we evaluate literature, I have seen that in 1960s, 70s, everything was started with Rutherford and Gilbert, continued it in 1980s. So it has 30 years of time, and this is a limited period. So from a few researchers' trials, I can make a short summary. So as a diagnosis, we know that during the childhood, ASD cases in their adolescence and adulthood evaluation, they are diagnosed, and we can see 85 to 90%, we see that ASD still persists. And in 10 to 15% of the cases, what happens? Once they were Asperger's syndrome or PDD or NOC, or treatment methodologies changed. We don't know this yet. We don't know what happens to the rest of this 10 to 15%. Let me talk about communication skills. There are three components, as I mentioned. In the adolescence, in the childhood period, they are evaluated again, and we know that communication skills improve a lot. 93% of adolescents and adults improve their language and communication skills. ASD diagnosed individuals without comorbid MR develop verbal language through expressive language often remains impaired and marked by speech abnormalities. This is not 100% fluent speech skill. They have some speech abnormalities and they have impairments in their speech and communication skills. And around half of those with ASD with comorbid MR never develop verbal language. Impairments in non-verbal communication, such as the coordinated use of gestures and facial expressions, also continue into adolescence and adulthood at all levels of cognitive ability. When we talk about social skills, in many of the trials, social skills occur, we know it, but they are not as improved as social skills, speech skills, sorry. Most commonly reported areas of social improvement are in social responsiveness and conversational skills. It's like a dialogue establishment. But when it comes to the quality of friendships and other relationships, we can see there are still such impairments that we have seen in this speech. 1% among the trials was found to be the healthiest social skilled group rate. Majority of the ASD patients do not develop healthy social skills. Baron, Cohen, and Wheelwright compared adolescents and adults with high-functioning autism or Asperger's syndrome with non-autistic controls. And in their trials, they found that although many adults with ASHFA do have friendships compared with people in the normal population, their social behaviors and skills are limited. Okay, when it comes to restricted repetitive behaviors and interests. In contrast to the lifetime improvement observed in communication and social functioning, the severity of the restricted repetitive behaviors and interests appear to be relatively stable over time. Mitigation or ease of the symptoms stay at 10% maximum. That's why we say they are stabilized. Many note that the form and complexity of these behaviors often does change substantially. During childhood, some children having behavioral rituals may suffer from more complex and sophisticated behavioral rituals. Predictors, when we look at the predictors in terms of this enhancement or improvement, IQ is the strongest predictor of the outcome, and also early language status has also been found to be a predictor of outcomes in adolescence and adulthood. The higher the IQ is, the enhancement between relationships and individuals is as well. Comorbidities. Psychiatric and medical comorbidities are quite high in this population, occurring in up to 64% of adolescents and adults with ASD and 38% of this group. Most commonly reported psychiatric disorders are affective disorders. Almost half of them has social anxiety and depression, and in adolescents we see depression as the most common reported psychiatric disorder. But apart from this, Tourette syndrome, attention deficit hyperactivity syndrome, and other disorders elevate as well. I won't repeat what other speakers mentioned. Exposure of their own body, masturbation in public, and touching other people can create big problems for the families of these individuals. If they are in public, they may confront with some legal issues. From childhood to late adolescence is associated with transition, we know it, and that transition is generally marked by improvements in core symptoms and some social skills. An estimated 30% of children with autism experience deterioration in functioning with onset of puberty. Gilbert was the first person who talked about that. In 2015, the recent study was developed by Pitchy and Sharf, and they have a theory, two-hit models. Knutson's 1971 multi-genetic mutations and cancer development related theory, and in 2001 Mainhardt adapted it into schizophrenia, and they dealt with the same theory, and they thought that Pitchy and Sharf thought that it can be interpreted for autism. I couldn't translate it into Turkish. That's why I put it as its original way. It says that we propose that the concomitant pressures of adolescent-specific developmental tasks together with the surge of pubertal hormones create a secondary hit for individuals with autism that their compromised neural circuitry cannot accommodate. I think this is worth to think for our topic. And on the literature, everything is focused and centered on healing. In 1980s, it was mentioned, and still on the literature, if you scan it, you can also see the same thing. Not many things have changed since 1980s. So this is my recommendation for future study. 10 to 15 cases that autism diagnosis does not persist, 30% cases of deterioration. I think they are very valuable areas for further discussions. I would like to conclude my speech with these words. The risk that children with ASD will have an increase in neuropsychiatric problems around the time of adolescence is substantial. So services for them such as schools, social services, family support, medical care should be planned as to cause minimal stress during that period. This is what I wish and hope for the future. Thank you very much for your patience.